Dr. Jayoda, can you share the screen?
Sorry, I'll try. Yes, I can. No? Can you see?
Yeah, can see.
You know? Yeah.
Can you move up and down? Right.
Sorry.
Can you move up and down on the slide?
Okay.
Right. Okay. Okay. Okay.
Can see, no?
Yeah, can see.
Is like a part of it hidden by the icons? No, you all can't see those, no?
No, no, can see.
All right. Okay. Okay.
Okay. We have about the participants. Uh, can everyone call their batch members to join soon? Otherwise, the madam will be unhappy.
Shall I start then?
Of you, you can.
Okay. So, good evening, dear madam and my dear colleagues. Today, I will be going through an overview of management of TIA and stroke in primary care, the importance of identifying TIA and stroke, and the importance of initial management, and also a little bit on follow up. So, it. Right. So, moving on to the definitions, stroke is sudden onset neurological deficit caused by a vascular origin lasting greater than 24 hours. So it's important to note that between stroke and TIA, that a stroke is a neurological deficit caused by a say blockage of a blood vessel or due to a hemorrhage due to bleeding, and the causes of vascular origin. And in contrast, a TIA or a transit ischemic attack is a brief episode of neurological dysfunction caused by focal brain ischemia without infarction, and that is a neurological dysfunction and is not a vascular issue. So usually symptoms resolve within 24 hours, and TIA is a warning sign of a potential stroke. And it's also very important to note that there are certain TIA and stroke mimics. And the importance of knowing this is because when we recognize TIA mimics, and I mean the other, and also the other conditions that mimic TIAs, it's important to note them because these conditions can resemble TIA, but they have entirely different causes and management and prognosis. And so, therefore, it's important not to misdiagnose any of these, because say many non-vascular conditions like say seizures, migraines, or hypoglycemia can mimic TIA. So mislabeling these as TIA can lead to unnecessary antiplatelet or anticoagulant use, which increases the bleeding risk. And missing the true cause, say for example, if we are missing a brain tumor or a Bell's palsy, it delays appropriate treatment of that particular condition. So early recognition improves patient safety and better patient outcomes. So this, of course, is a general list of TIA mimics. Say postictal Todd's paralysis, transient global amnesia, hypoxia, sepsis, and metabolic causes such as hypoglycemia, hyponatremia, and migraine-related hemiplegic migraine or migraine with aura can also mimic a TIA, and functional neurological disorder, conversion disorders, then peripheral nerve disorders like Bell's palsy, vestibular disorders such as vestibular neuritis and BPPV, other infectious conditions such as encephalitis, multiple sclerosis, and other structural non-stroke conditions such as brain tumors, subdural hematomas, then say other cardiovascular causes such as syncope and arrhythmias. Even alcohol intoxication can mimic a TIA, and drug overdose. So it's important to, I mean, this is just a summary of these conditions and the key features and how to sort of differentiate between the TIA mimics and actual TIA. So one important thing to note is that in TIA, generally we will have negative symptoms, that is a loss of a function, whereas most of the other TIA mimics will have positive symptoms. For instance, Todd's paralysis will have jerking, which is a positive symptom, and migraines the patients will come up with flashing lights, zigzag lines, or tingling. Then hypoglycemic patients will have positive symptoms such as tremors. Likewise, that is one key difference between these TIA and TIA mimics. Then the key diagnostic clues, like I said, for TIA and stroke, in contrast to the conditions that we mentioned above, is that there will be sudden onset and resolution of neurological symptoms. So in case of TIA, there will be a resolution of these neurological symptoms. Then negative symptoms, like I said before, there will be loss of functions rather than any abnormal sensations. Then there will also be focal signs like unilateral weakness, aphasia, vision loss, etc. Then a patient will most of these patients will also come with have other risk factors such as hypertension, diabetes, AF, smoking, or elderly patients. Then they will also have most of these patients will have normal glucose and imaging in early stages. uh, so, a little bit on stroke management of stroke in primary care. Like the most important things that we need to know will be one thing is recognizing early signs of stroke. So we have there's a mnemonic called Be Fast, that is balance. So there'll be so these are the ones. These are the symptoms that we can the patients we in terms of screening the patients we can go through, see if the patient has any of these symptoms, such as any imbalance, eye symptoms, face drooping, arm weakness, any speech difficulty, and time to act is we have to act fast. So that is the mnemonic Be Fast. Then in management of stroke in primary care, we have to recognize early symptoms and urgently refer these suspected stroke patients within the golden window. That is within, usually we say within the first 4.5 hours for thrombolysis. And we generally do not start aspirin if hemorrhagic stroke is not safely excluded. And if facilities are available, of course, we have to make sure that an NCCT brain is done in these patients. And also, we have to provide basic supportive care such as oxygenation, blood sugar control, and if any airway support is needed. So, indications for immediate admission of stroke patients. Say a patient presenting to a clinic having any of these Be Fast symptoms, and then you suspect stroke in these patients. Some of these patients will require immediate admission. Say, for instance, if a stroke patient, acute stroke symptoms are, if a patient presents within the, if a patient presents with acute stroke symptoms for the last 24 hours, then if the time window for thrombolysis or thrombectomy, like we said before, was within, if a patient presents within 4.5 hours, we have to refer for possible IV thrombolysis. And if the patient has symptoms, say presenting within 6 to 24 hours, then we have to refer for possible mechanical thrombectomy. And if one presents with the impaired consciousness, seizures, or uh, lower GCS, and if a patient presents with symptoms of raised intracranial pressure, or if there's any new onset atrial fibrillation with neurological signs, or any uncontrolled hypertension or hypoglycemia associated with these neurological symptoms, we have to immediately refer these patients to say we have to immediately admit these patients. So in this case, we do not wait for any of these investigations to be available, say full blood counts or ECGs. We do not wait for them, and we also do not keep these patients in the clinic to observe for any, say, deterioration or clinical progression of disease. uh, so that is the, briefly about the management of stroke in primary care and what we need to do. And in terms of, the main discussion today is, in fact, the management of TIAs, identifying and the importance of identifying TIAs, and how to identify and how to manage TIAs in primary care. So, like I said, the importance of early recognition of TIA is TIA is a warning sign of impending stroke. Say up to 10% of there is up to 10% of stroke risk within the 7 days. Within 7 days after a TIA. So early recognition and intervention can prevent permanent disability, and primary care is often the first point of contact in patients presenting with TIA. So, timely diagnosis will ensure risk stratification and urgent imaging, or, if needed, referral and initiation of antiplatelets and risk reduction strategies. So, these are the four things that we need to do as primary care physicians. First, we have to stratify the, we have to stratify these patients according to their risk, and we have to do whatever the investigations that we need to do, and then we have to initiate antiplatelet therapy, and then adopt risk reduction strategies. Uh, so the TIA symptoms the patients present with will be sudden weakness of numbness in the face, arm, or leg, and slurred speech or inability to speak. Then visual, they will also come up with visual disturbances, and then most of these symptoms will resolve within minutes to hours. But what we need to know is, although the symptoms resolve, the risk remains. So always ask about the onset time and any recurrence, and we have to keep in mind that TIA is a neurological urgency, and thus we have to manage as an urgency, and we have to manage it in primary care. So the initial clinical assessment is, after you have to just obtain the history of, say, time of symptom onset and any focal deficits, duration, and of course risk factors. Then in terms of examination, the entire neurological examination should be done, and then we have to look at cardiac we have to auscultate for any arrhythmias and any say whatever if we find any murmurs, and we have to do the fundoscopy as well, and we also have to look for cardiac carotid bruits. Then this is very important, the risk stratification of patients presenting with TIA. For all patients presenting with TIA in primary care, we have to stratify these patients according to this ABCD squared score, where A will mean greater than 60 years, age greater than 60 years, and B is BP greater than 140 to 90, 140 upon 90, and C is clinical symptoms. That is, if patient has unilateral weakness, we give a score of 2, and if speech only is affected without any neurological deficit, then the score will be 1. Then duration greater than 60 minutes, score will be 1, and between 10 to 59 minutes, score will be 1. Uh, Diabetes, we give a score of 1. So altogether, the ABCD squared score will obtain a score out of 7. And if there is a total score of greater than or equal to 4, we say there is high risk. So therefore, we have to keep in mind that these patients are at a higher risk of getting a stroke. And this is actually the actual figures. And when sort of when telling the patients about the management, and when educating the patients, we can of course get their ABCD squared score and tell them exactly what their stroke risk is. So say, for instance, if a patient has about 0 to 3 points in the score, their 90 days stroke risk is 3.1. In contrast, say if there is a score of 4 to 5 points, 2-day stroke risk is 4.1%. And if there is 6 to 7 points, 2-day stroke risk is 8.1%. So this says within the next 2 days, what is the percentage, the risk of getting a stroke in these patients. Uh, then the primary care investigations that we need to do, of course, the usual screening investigations like fasting blood sugar, serum lipids, and ECG is required. We have to do an ECG because we need to also exclude or confirm cardioembolic TIA, and full blood count, creatinine, EGFR needs to be done, and then of course we have to do a carotid duplex in each of these patients, and then imaging, of course, there's a bit of a controversy in terms of imaging, because they say CT brain will not quite say, if a patient has a TIA and there is no infarction as such, so a CT brain will not really show a infarction. So the gold standard investigation to really do is MRI brain with DWI. That is the most sensitive in detecting minor infarcts that may mimic clinical TIA, and it's the gold standard. However, in settings where there is in poor resource settings, I mean, it is advisable to at least do a CT brain. Uh, then so like you said, so this is the role of NCCT brain, again like we said, in resource poor settings and also in instances where hemorrhage is suspected, and in patients on anticoagulants or with bleeding disorders, and to rule out mass lesions or subdural hemorrhage. And we can identify some early signs of infarction, although it will not be as prominent as as shown in an MRI. The limitations of NCCT is that it is insensitive to any acute ischemia. And if TIA symptoms have resolved, NCCT has limited value in detecting the underlying cause. However, we still, in most of our primary care settings, an NCCT brain will be done. As in, we'll refer the patients for an NCCT brain. So the referral criteria, I mean, this is the Sri Lankan guidelines say that we need to refer the patient urgently within 24 hours if there is a BCD squared score of greater than 4, and if a TI occurred in the last 7 days, and if there's atrial fibrillation or suspected cardioembolic source, or there are crescendo TIAs. Crescendo TIAs are if there are 2 or more TIAs in within a week. Then they say to refer to a neurologist urgently. Then the most important thing is the immediate medical management. That is, again, antiplatelet therapy in patients presenting with TIA. So it's pretty simple. I mean, although this looks very busy, it is simple. First thing is, if a patient presents with a TIA and the patient is, it's the first time that the patient presents with any type of any TIA, then and we have to make sure that the patient is of non-cardioembolic origin. That is, so if the patient presents within the first 24 hours, we give aspirin 300 milligram stat along with clopidogrel 300 milligram stat. Then, say a patient is intolerant of clopidogrel or has past allergy to clopidogrel or something, then of course we adopt a aspirin only strategy, where we give aspirin 300 milligram stat at the moment, at that time. And then after 2 weeks, we start the patient on 75 or 150 milligrams daily. Then if a patient has aspirin allergy, then we only give clopidogrel 300 milligram stat. And it is also important to note that when giving aspirin, it's important to pair it up with a PPI because of GI, gastrointestinal irritation. Then say if a patient is already on aspirin, then of course we can give a clopidogrel 300 milligram stat at that time. And then of course I'll tell then usually now after the stat doses we give dual antiplatelets, that is aspirin 75 milligrams and clopidogrel 75 milligrams for 21 days, and thereafter we have to continue clopidogrel 75 milligrams indefinitely. So going back, if a patient presents with the first ever TIA and he is not on any aspirin or clopidogrel, we give aspirin 300 milligram stat and clopidogrel 300 milligram stat, and then continue aspirin 75 milligrams and clopidogrel 75 milligrams for the next 21 days, and then continue clopidogrel 75 milligrams indefinitely for life. In this aspirin only strategy, of course, similarly, aspirin 300 milligram stat will be given. Then after 2 weeks, you taper it to 750 or 75, and then continue aspirin 75 milligrams indefinitely. In case of aspirin allergy, we give a clopidogrel 300 milligram stat, and then thereafter give clopidogrel 75 milligrams indefinitely. Then if a patient is already on aspirin, we give clopidogrel 300 milligram stat. Uh, we do not load the patient with aspirin, just give a clopidogrel 300 milligram stat, and then continue clopidogrel 75 along with the aspirin 75 milligrams the patient is already on, and then switch to monotherapy. And say usually if if a patient is on aspirin because of IHD, ischemic heart disease, then they say so the patient has to be on aspirin for ischemic heart disease. But usually following a TIA, the preferred monotherapy is clopidogrel. Say a patient has both TIA and IHD, the usual preferred monotherapy again is clopidogrel 75. Then if the patient has a cardioembolic TIA, if we have a suspicion of cardioembolic TIA, of course, we do not start the patient on any antiplatelets. And the other thing is, if a patient is already on dual antiplatelet therapy, say following say some sort of PCI or something, if a patient is already on the dual antiplatelet therapy, we do not give additional loading doses to these patients, but rather ask them to continue. However, it should also, if a patient has already been on DAPT and the, I mean, still gets a TIA, then there is some antiplatelet failure. Therefore, for this antiplatelet failure, we need to investigate why the antiplatelet failure occurred. Yes. A little bit on this cardioembolic TIA. So the commonest causes of this cardioembolic TIA is atrial fibrillation, and it could also happen with recent myocardial infarction with LV thrombus, then rheumatic mitral stenosis, any mechanical prosthetic heart valves, dilated cardiomyopathy, or PFO in young adults. So in these patients, it's important to do urgent neuroimaging because we have to say rule out infarction or hemorrhage before starting anticoagulation on these patients. So we do a NCCT or an MRI brain to rule out an infarction or hemorrhage. Then we do a cardiac workup, of course, initially ECG, and then we have to do a Holter monitor later on. And we do not start anticoagulation immediately until we have safely excluded hemorrhage. And if again, we have to make sure that if there is an infarct, the infarct size is not too big either because of the risk of hemorrhagic transformation. Then, if AF is confirmed and imaging excludes hemorrhage, of course, we have to start the patient on oral anticoagulation, either a DOAC or warfarin. So timing of anticoagulation initiation. So if there is no infarct or minor infarct in the NCCT brain, then we start anticoagulation within 1 to 3 days. And if there's a moderate infarct, we wait for at least 1 week. And if there's a large infarct or hemorrhage risk is there, then we delay up to 2 weeks. And with the, we consult a neurology team and decide on when to start the anticoagulation in these patients. And the Hasplett score again is important because if it is greater than or equal to 3, it will require close monitoring. However, just because the Hasplett score is high, it is no contraindication to starting anticoagulation in these cardioembolic TIA patients. So the initial warfarin dosing, the standard loading dose for most other adult patients will be, we start with 5 milligrams daily for the first 2 to 3 days, then check INR on day 3 or 4. And in elderly or frail patients and patients with liver disease or those taking interacting drugs, then we start with a lower dose of about 2 to 3 milligrams. The target INR will be, if a patient has an AF and having a cardioembolic TIA, then the target INR is 2.5. And this adjustment is typically done weekly, changing 10 to 20% of the total weekly dose. So this is when usually if the INR is less than 1.5, we increase the total weekly dose by 10 to 20%. Then if it's between 1.5 to 1.9, then slight increase in dose. So we just give one extra dose that week. Uh, then if it is between 2 to 3, of course, that is the target range, and we maintain the current dose. And if it is higher, of course, we reduce the dose slightly or skip one dose if there is minor risk. Likewise, I mean, if there is that is how we have to adjust the doses, and the dosing adjustment is done weekly. And ultimately, we obtain a INR of between 2 to 3. So we always recheck INR within 2 to 3 days after dose changes. And we also have to consider interactions like antibiotics, antifungals, amiodarone, and NSAIDs before dose changes. And we monitor for these bleeding symptoms or any signs of clotting. And we educate these patients on dietary vitamin K consistency, say in terms of consumption of green leafy vegetables. So yes. After a TIA, other thing is patient education and safety netting. So we have to highlight early stroke risk after TIA. So by using the ABCD squared score and using the exact figures, we can tell the patient what exactly their stroke risk is after the TIA. And we have to educate the patient about the fast signs, the B fast signs that we spoke of earlier, and for the patient to be able to identify signs of stroke. And we have to explain the purpose and the potential side effects of the antiplatelets and reinforce the importance of adherence and lifestyle modifications. So we have to tell the patient that the patient will have to be on lifelong antiplatelets. Then moving on to secondary prevention, of course, we have to start statins in these patients. Usually, high dose statins at 40 to 80 milligrams of statins will be required, where we target an LDL of 70 milligrams per deciliter. And if a patient has hypertension, has hypertension, we start ACE inhibitors or ARBs plus with say calcium channel blockers. Uh, and we target for a BP of 140 by 90. And say a patient also has DM, we target for an HbA1c of less than 7%. Uh, then the lifestyle changes, of course, the usual. We have to ask about to ask the patient to engage in adequate physical activity and weight loss if overweight, and screening and treatment for sleep apnea. Again, if say if indicated, and nutrition and counseling, we say DASH diet, low sodium, lean proteins, reduce saturated and trans fats. Then the smoking cessation, abstinence of alcohol consumption should also be promoted. Then the follow-up plan of these patients after a TIA, we review within 7 days, and we see we monitor symptoms and BP control and medication adherence and tolerance. When you also find out if there is any sign of another TIA, and ask the patient from that and see if a crescendo TIA has occurred, and refer to a neurologist, of course, if these recurrent TIA stroke symptoms are there. And we have to ask the patient about side effects from antiplatelets and intolerance to antiplatelets. And poor control of risk factors should also be identified at the time. So that's briefly about the management of TIA and stroke in primary care. So in conclusion, we need to know that TIA is a neurological urgency requiring rapid action, and primary care providers are key to early intervention because that is where they present to, and it's important for us to identify and manage these TIA patients. Appropriate use of ABCD squared score and antiplatelets and referrals can prevent major strokes uh, and can lead to better patient outcomes. And we have to follow national and international guidelines to improve outcomes. Thank you.
Jana, you rushed the presentation, so there are things that you could have like explained. Now, for instance, it's this now this forum is like open for the discussion now. Now tell me, because you rushed, why there you are very like the people after this, after listening to this presentation, they are not sure whether to go ahead with NCCT or not. That is one thing. Other thing is, in primary care, like we do primary care, but we used to do NCCT because it is non-contrast. We can do it as outpatient. So we do it. And why we do, and because though it's mainly TIAs, unlike strokes, strokes, of course, vascular, mainly the problem. Here, the neurological. And because of that only, there is no place for NCCT. Now, they are, right? But anyway, no, there is no place. But all the time, there's but. Why we do CT, NCCT? Just tell, this is open for you all. I asked this question. Why you still, we know there is no, because it's not vascular, because of that there is no kind of like any infarction, sort of any kind of cut off the blood supply to the brain parts. Because of that, we cannot see. Very true. I know that. But why you do? Why you do? Because there are like how many? There are about 24 registrars, or no, 23 registrars. Think why you do, why you ask these patients like for the NCCT? Because you rushed the thing, because of that, they didn't, I mean, can you please go through those things? Can you just go to those slides?
The one reason could be, madam, sometimes as a DD, we have to exclude other causes like TIA or stroke mimics, such as
Yeah, one is
self-amplifying
the
lesions.
TIA mimics. First
Yes.
thing is it could be a TIA mimic. Though it's at the early times, at the because it's a primary care, they come with a very vague symptoms. Sometimes it's just retrospectively you see the patient, right? Because we don't see any kind of symptoms, but there may be mimics. So then there's some kind of very sort of normal. Normally we get this time, so this symptom and sign, but these things are very vague and you are not sure whether it's a TIA or not. So in those instances, yes, definitely, if it is TIA mimic, we should go, because here we see patients with the retrospective symptoms we don't see right now maybe. And the other thing is, what are the other instances you do the TI? Because now go to those limitations. Of course, they say a lot of things, but you better think. Okay, right now tell me. These, of course, these pretty obvious ones are there. Okay. Now, what are the other instances we do? Why we want to do NCCT? Think other than this. Why we want to do?
And to also confirm that there is no infarct, and I mean to say that it's, I mean, if there is an infarct showing in the NCCT brain, then of course it's more towards a stroke.
No, but anyway, the stroke, of course, we have some kind of symptoms then. But just go to the slides, but embolic ones. Embolic one, this is the next slides. It's there, you mentioned. Next slides. But there are two types. No, you have to think of two things. No, not that. Yeah, that's what, the first slide, slide before, just go through that. Why you want to do that? So these are the instances. So cardioembolic TI is these are the common causes, right? So that is the reason we go for 2D echoes, right? Okay, fine. Just to check the functional and the structural changes in the heart. Okay, fine. And then the next slide, let's go to that. Now just go through why this thing. Go through that and just think why you are doing that. Urgent neuroimaging, why? There is again, they say non-contrast CT. Right? So here, if you are not sure, it's because it's an emergency. So because of that, we are not sure whether this is, you have to compare the slide before and now, right? It's a cardioembolic or not. So better go for this thing. So we have to do the non-contrast CT in these cases, because if we have my facility for MRI, definitely we go ahead. But here in Sri Lanka, MRI brain is a huge issue, right? So it's difficult to get a date. Because of that, since it is an urgent thing, urgent neuroimaging is important. And the rest of the things because the patient needs anticoagulation. So because of that, it's better to rule out any hemorrhages. Got the point? Because of that only, can you go to the slide before? Slide, early slide. Jayada, the earlier
Yes,
one.
madam. Wait.
Yes. No. Yes. No, not that. The slide. Not that. One before this thing. No, not that. Go down. Cardioembolic one. The causes for cardioembolic one.
All right.
Yes. Right. So then here, if a patient has this history, do you think the person, like now the patient has some signs and symptoms of TIA. And on top of that, the patient has these things. Are you very sure the patient's TIA is due to this or something else? Now tell me the answer. Are you very sure?
No,
Or you are not sure?
not sure.
Not sure. He may or may not. But in these instances, do you have to go for imaging or not?
We have to do
You have to do.
this
For what?
to rule out a hemorrhage before
To
starting.
rule out hemorrhage, any kind of hemorrhage. Because you see patients at the very few hours sometimes. Because of that, sometimes we may not get all the symptoms. It's better to go, because that's why we admit to do all these things, right? To get the NCCT brain, to do this and all the other rest of the things, but there are 4 things we had to do. But because it's unlike the stroke, what do you think which is more dangerous, a stroke or a TIA? Now tell me. Because there are a lot of listeners, which is most dangerous. It is more dangerous. This is open for you all now. Think why you think is more, but it is more dangerous now. Talk when how many trainees are there?
TIA is more dangerous, madam, if it is
Yeah,
cardioembolic
more
TIA.
why? That's why I want to stress this
Yeah,
point.
because
That's why
it
I asked
can
you all to do this presentation. Why it is more dangerous? Not clear. It's not clear. I cannot hear you. I think Sachit, isn't it?
Madam, one reason is, the stroke could be most of the time confined to one area of the brain, whereas TIA, it could give rise to multiple embolies, which can, in fact, kind of.
If it is
Because
cardioembolic, if it
can
is
be
cardioembolic. Yeah.
developed
I cannot hear any of you all. Why is that? What is this? The platform? Is it your personal one or the college one? Huh? This one? The Zoom platform? It's not
Helical.
The college one, madam.
college one. Why it's not clear, no?
No, I think the personal Wi-Fi or the internet connection errors are there, madam. That's why. Not with the Zoom, madam.
Right. Okay. Now tell me. Why?
One reason is, madam, if it is cardiac emboli TIA, there can be multiple emboli which could infarct multiple areas of the brain, whereas stroke, it most of them confined to one area, madam.
That is just one reason. What are the other things? Think. That is why I have chosen this thing to you all. Think why it is more dangerous.
Madam, stroke diagnosis is straightforward, but TIA is a doubtful diagnosis.
Exactly. that is already the patient has symptoms. With the symptoms, you can get all the differentials because you can do a nice neurological examination and you can come to a kind of a conclusion. Here, it's kind of like we have to assume the assumptions are there because of these things. It could be this, it could be that. And if you miss the diagnosis, what will happen? It's a mainly neurological, and the stroke risk the next 24 hours, next for 72 hours, next 1 week, there is a problem. So if you miss it, if you do not calculate the risk, there will be a lot of issues. And here, unlike the stroke patients at the beginning here, even sometimes you have to go ahead with a like warfarin because it's due to AF. That we don't like see the AF at the beginning, the patient is okay, but with a history of some kind of a neurological deficit. And next few hours, we don't know what will happen to the patient. So because of that, you should nicely evaluate the patient. It will be of a kind of a, some clue to a TIA. What are the, what are the instances you miss a stroke from TIA? Any instance where you can miss stroke from TIA? Nobody? Just tell me. I think I have already told you, all right? What are the kinds of like strokes you know? Types? Okay.
Sensory stroke and
Exactly, the sensory stroke. Could you please give a brief description of what is sensory stroke? What are the symptoms, at least what is not the definition, textbook definition. Just tell me the symptoms of sensory stroke. Anybody?
so usually a sensory stroke will also present with the sudden onset of, say, numbness or any mostly sensory symptoms without any motor weakness. So there will be no speech disturbance as such, but
Subjective
will
or
be
objective?
objective.
It's subjective, objective.
Objective.
Yeah, so then you can see what when you examine, you can.
No, I mean, we can, the patient will come up with, say, a numbness and reduced sensation.
Mm.
And
Can you demonstrate it?
no, can't.
You cannot. So then what kind of thing you judge? So either maybe you think it's a sensory stroke, or else it could be because according to the description, because you cannot see anything when you examine. It could be you
Yes.
think of TIA.
Yeah, yes.
Yes. But the pathology behind those two, what's the pathology? Now you come to the first slide. What is the pathology behind those two?
The sensory stroke will have a vascular pathology, whereas the TIA will have a neurological pathology.
Pathology. The two pathologies. You deal with two type of pathologies. So your approach should be like this, different. If you do not deal with the neurological emergency here, what will be the next is the vascular thing. That means a stroke, isn't it?
Yes.
Yes. So that is the reason we have to nicely go through all the, like here, the mimics, stroke mimics. Could you please go to the stroke mimics? Anybody can describe the symptoms and signs of each of these things, because it's not complete. We have a few minutes. Stroke mimics. Sorry, not stroke, TIA mimics. It's difficult for you to go to that? Jayoda? Hello? Hello, Jayoda? Can't you hear me? I think problem with this line, with her line. Jayoda? Any problem, Jayoda? Is Helika there around? Helika, what's going on? It's what's going on here now.
I'll check, madam. I'll check with Jayoda, madam. Hold on.
I think the listeners, I'm telling TG comes, you have huge homework by listening to the presentation, just the outline, because I know I have seen a lot of different ways of managing a TIA, because the way you start antiplatelet, the way you continue antiplatelet, you're not sure. Because of that, please go through the chart, because it's nicely highlighting the ways you have to give antiplatelets and when to sort of dual antiplatelets should stop, and how do you do the continuation, and if the patient is sort of resist or some kind of a allergy to clopidogrel, allergy to aspirin, already on aspirin and dual antiplatelet. So these are the different ways like how do you do the job. So that's what it's very important, because if you are not sure as a primary care, because you are the person who see the patient at the beginning. So if you don't do your job, it's the patient, you will lose the patient's future. Like the patient will ultimately end up with a permanent damage, right? So don't, like, you cannot do those things. Because of that, please stick on to this. Please go through each and everything. And please, if you can, I think Jayoda, I think, who are the people? Subodha, could you please get this thing to the
Yes,
HNF clinic where you are there and get a printout, and please take with you all or keep it in under the as a table, or where, I mean, like under the glass in the table. So then it's good for you all if you cannot remember. Otherwise, you do this and that. Not this slide, the previous one with the TIA mimics I want. So this is TIA, the TIA mimics the, I mean, the first, the other slide. They're not the key features. Right. Yeah, these are the things. Okay, fine, go to that. Those things, of course, okay, fine. Post-it slide. This is the slide. It's a migraine related, hemiplegic migraine, right? The functional neurological disorder. These are, of course, very common in primary care. The Bell's palsy, of course, like sometimes, because they usually have some permanent damage, like then permanent in the sense like maybe lasting for weeks and maybe days. But anyway, here, the migraine-related functional psychogenic ones, because these are very important for y'all, then you give unnecessary antiplatelets plus unnecessary exposure for imaging, right? Other unnecessary, so like using resources. Because of that, what you really need is to get the correct data. That means correct information or history taking, or else the consultation. This is very important. Otherwise, you ask one or two, and then you assume it could be a TIA, and you say it's a TIA. Okay, fine, I'll start. I think how many times you think yourself, how many times you miss that type of thing. You think it is a TIA, but when you go like sort of a very lengthy discussion, then you can find it is not a TIA. The same way, it looks like just a mimic, and then when you closely or when you talk to the patient very sort of, very comprehensively, then you can think, you can diagnose it as a TIA. So that part is very important. The patient will come to you first, right? That is why I want to talk about TIA more than stroke. Stroke, of course, the secondary, once you see that this kind of a permanent like weaknesses like motor or sensory deficits, definitely you refer the patient. But here, you don't see anything. Because of that, the patients, of course, they don't know the gravity, and even the relatives, they don't know the gravity, and they do not know if they don't go for any kind of investigations or the management plan, what they will get in the next few days, hours, or weeks. It is you are the one who should sort of educate. So you have to give all the information and get the sort of understanding, not only the patient, as well as their relatives. So that is the thing. But most of the time I've seen the patients, they just stop after a TIA. I think you also can also see the patient, the compliance rate is very poor. Because there is a problem with the primary care, the person who sort of give the instructions. Secondary care, we don't expect things from secondary care people. When you send the person for the investigations or the rest of the thing, don't expect they have to tell everything, because you are the person who saw the patient first, and you should give all the information to the patient, right? So it's the reason why I have sort of wanted you all to know this thing properly. Is I've seen there are a lot of people who miss this thing and who manage the patients not in a correct way. So I think it's my time is over, because it's you all can do the discussion. If you have any questions, ask from Jayoda. I'm also there to support. It is you, and you are the people who face for the exam in few months.
Thank you, madam. And thank you, Jayoda, for the presentation. I just have two questions actually. First, in case TIA or stroke mimic like a hemiplegic migraine, still do we proceed with the neuroimaging as a baseline investigation? That is question number one. And then question
Yeah,
number
it's
two
not, we cannot hear your question correctly. Can you please?
hello.
It's
Uh,
not clear.
Madam, he asked whether if we suspect hemiplegic migraine in a patient, uh, do we still do neuroimaging in these patients whom we think that there is a TIA mimic?
I cannot hear you. Like, sir.
Madam is asking whether we do neuroimaging, that is like an NCCT brain, in these patients in whom we suspect a TIA mimic.
What? So why not? That's what I'm telling. Why not? TIA mimic means how many TIA mimics are there? If it is a functional, do you have to do this thing? If it is a functional, no. So it depends, it's more closer. Like, what are the TIA mimics? Why I've talked about them now. I just answer because you are the person you should answer, not me, right? But anyway, the TIA mimics that I just now I told you, no? What are the things? It's the other slide. The first one. Now the problem is TIA mimic or TIA. Are you very sure which is? The migraine with aura, you don't have to do. Yes, I know. If it is a functional thing, you don't have to do. Right? But other things, why you are not moving the slides? Is it a problem with like doing all these things?
Madam, I think some internet connection is even out.
It's because I think you have not studied. I think, I don't know why you are not like. The other one, man. The one, the beef. Yeah. Mm. So now there are things, right? What are the other things in what are the other conditions you want to do TIA, the CT, the NCCT brains in these conditions?
Any condition which has in which we elicit a focal deficit, we have to do an NCCT
Exactly,
brain.
the focus seizures, we do not know where the things. If you are not sure, because TIA mimic again your assumption, right? Or else stroke mimic again a assumption. Or else just a TIA again assumption, because we don't have anything right now. But if you are very sure about your diagnosis, and if you are very sure that it's not cardioembolic, of course, you can sort of, okay, you don't have to go for any imaging. But how can you sure about that? So that's the still, when we refer a patient for an NCCT brain, if you are very sure that the people who are doing that, they say nicely, they can, okay, no need of doing NCCT. But anyway, still, if they are doing, why they are doing is they are also not sure according to the presentation. Because next few hours, there will be totally different picture. So that is the reason. If you miss a hemorrhage, doing NCCT is nothing, because we don't give any contrast, right? We don't gain things, but losing is like a problem. Because there is no indication for NCCT brain, because we don't gain things, because we can't see any infarction, but we may miss things. So all the time we have to give a kind of a, like, all the time negative payoff, positive payoff. We know those things. If you miss a thing, it's a problem. That is why all the time think what the benefit and what is what you lose by doing. Because of that only, still it's a debatable topic. How nobody can say, yes, this is TIA for sure, unless the patient maybe sort of after 3-4 weeks know any other new signs or symptoms, then you are very sure. But still you are not sure. That is a problem. Is it the answer for me, this thing, Helika? Anything you want more than this?
Yes, I think that's the answer.
Okay.
Madam, second question, madam.
Then
To
okay, Jayoda gana mama present correct na. Right, okay.
the second question. What is the place for MRA angiogram in place of TIA? Is there a routine recommendation in our guideline?
Angiogram.
MRA, magnetic resonance angiogram, to see any stenotic areas, not the MRI DW.
You mean if there is a cardioembolic TIA?
No. For assessment of circle of Willis stenotic area, magnetic, the MRA and MRV are sometimes done in private sector to see the atherosclerotic stenotic area. Is there a recommendation for a routine MRA, MRV post TIA?
In fact, I went through the local guidelines and the international guidelines, but I did not find such a recommendation.
No, there is no such recommendation, because in private sector, anybody can do anything. But so that is because at the beginning, according to the guidelines, those investigations, what highlighted here in the presentation, you must. But if you like sort of you have some kind of a pathway, like, okay, the person has this, because there are a lot of DDs, no, accordingly, you may choose what is the next step of, what are the next levels of investigation. You may go for those levels, but at the beginning, you should know these are the mandatory or the things you should do. Other thing is Helika, yeah, there may be it's better you should know, but as a primary care physician, though you know those things, it doesn't change any of those, because since you are not kind of requesting, or you are not dealing with any of those. But here, if you do not know those things, huge problem, right? You should know those things. Whether you do not know those things, not a problem. But here, better it's your knowledge, but it's very important. But you should do, but according to the cause, then you can choose the next level of investigations. But they are not mandatory for because what's the scenario? Why you want to do those things? Just imagine why you want to do just what is your suggestion? Why you want to do? In all cases, what do you want to do? It depends on the cause, no? Then it's
Yes, madam.
but here, what do you want to do? Any angiograms, right? Is it?
Yes, madam. Some I have seen some physicians doing, madam. That's why I also had the doubt.
Yeah,
Whether
doubt in the sense now, what is the definition of TIE? Where is the problem? Mainly the neurological, right?
yes,
So that's the thing. If it is cardioembolic, and if you think of the next thing it's related to the vessels, then of course you can go for those things. Not with the neurons. Now you
And
got the
Angelica,
point.
and Angelica, apparently in following a stroke, of course, in the local guidelines, they say MRA of cerebral vessels can be done following a stroke. But since, like Madam said, TIA mainly we are it's mostly neurological. We do not in the TIA workup.
That's the thing, this thing is a problem. But anyhow, because stroke, of course, okay, Helika, because they have the problem with the vessels, no? The problem is in the vessel. Of course, you can go ahead with that, but not TIA.
thank you, madam.
Jada, I have a small doubt on this ABCD square score.
Yes.
Yeah, under the C, you said some neurological deficit. Are we going to give points to the examination findings, or if those are present in the history, are we going to give points? Because sometimes
No,
they
in
are
fact,
neurologically normal. Yeah.
yes. So, under clinical findings, we are mainly concentrating on neurological deficit and if there's speech disturbance. So, if say now some of these patients might actually come with these symptoms, and some might even say within the first 24 hours they have gotten the symptoms, and then they come to us later after resolution of symptoms. So, in that case, of course, we will not be able to objectively see a
Deficit.
weakness in them,
Yeah.
deficit in them. But if they say that they dropped an object or they complained of a deficit, we usually consider it to be two. Uh, but I mean, like you said, if at the point of examining, if the patient has, of course, again we can say, but most of these patients mostly come after resolution of symptoms. So we will not be I mean, we will not be able to objectively see it, but in the history, if they say it, yes, we take it like that.
Okay, thanks.
Anyway, it's good that I think it's a good eye-opening for you all, because there are a lot of questions, means you need to sort of refer more guidelines and to understand what are the sort of symptoms and signs of other mimics here, and then only you are very sure. And then you have to sort of do some consultation with a query of TIAs or other mimics. Then only it stays in your brain or your mind, whatever. But anyway, I think it's a good eye opening for you all. That's actually, this is only for registrars, I suppose, not the medical officers, because you are the people who manage these people. Most of the medical offices, they refer patients. Here you cannot do referral without doing the initial assessment and giving initial sort of a management plan. So because of that, it's your topic and you should know what's you have to do and what is your responsibility, right? And when it comes to the past, like past 10 years or maybe 5 years, each and every year, sometimes, you get like cases at the MCQs or skis and long cases with TIAs. So whenever they used to give this kind of presentations for your exams, because of that, please read and please get the practical sort of exposures for this, and keep those things in your mind, just as candidates, as well as maybe the SARS also there, as the clinicians who can do the best for people. Okay, then I think there are some 2 messages. All right, so this is just for thanking ones. Okay, thank you very much. And
Thank you
there's a
very
problem
much,
with
madam.
Sandamali asking a question. If patient present after 3 or 4 days after TIA, how to give antiplatelets? Do we have to wait? No, I think Sandamali, so we don't have to like 3 to 4 days means now if the patient has other sort of, why we cannot do why don't we give antiplatelets here? We have to give antiplatelets. Only problem is hemorrhages. You think that if the patients with hemorrhages, they this come without any kind of symptoms after 2 to 3 days or 3 to 4 days? No. So you have to have kind of giving antiplatelet is not a problem, but that case it could be a mimic. Then you better go for a NCCT brain, just to rule out. Not only that, we do all 4, like we do ECG, we do carotid duplex, and we do CT brain, NCCT, as well as 2D echo. So just to check whether it's cardioembolic or not, whether it's hemorrhage or not. So any kind of, why the ECG, whether it's AF or any other thing related to the heart, right? Or maybe any the structural damages, just you can see from even the ECG and the carotid duplex, how far the sort of the problem is, maybe the block is, whether we had to go for the end arterectomy or not. So there are each and every investigation gives some kind of a pathway for you to go. This is because of that is very important, but no harm giving a starting dose, because only problem is a hemorrhage. But if you think that we have to stop giving antiplatelet after 2 to 3 days, thinking of a hemorrhage, it's sort of is wrong calculation, because 3 to 4 days means if there's a hemorrhage, the patient cannot stay like that. So with all the symptoms they come, this no harm, right? Is it the answer for answer?
Thank you.
Sandamali?
Yes, madam. Yes,
Okay.
madam.
How are
Thank
you
you.
then? How are you? Good? Yeah, not talking, my God.
Yes,
Okay
madam.
then. And now I
Yes,
ask, how are
continue.
you then? After a long time, I heard your voice.
Yes, madam. Yes, I'm okay, madam. Thank you.
Okay, good. Okay then.
Okay,
So,
madam, thank you very much for sharing all the reading material and the guidelines. And thank you for correcting the presentation and all the advice given.
okay then, let's wind it up now. 10 minutes to, or 15 minutes to 11 o'clock. We'll wind it up. Okay, there's a good discussion after that. Okay.
Good
Uh,
night.
Thank you, Dr. Jayada, for this interesting presentation. And thank you, madam, for the guidance, as always. With that, we will wind up for today. Hope to meet you again in another 2 weeks' time. Good night.
Good night.
Good night.
Good night, madam.
Good night, madam.